Everything I possibly can to shut the pain off for a while. Okay? I'll do whatever nerve block I have to do. I'll implant whatever device I have to implant, just so I can quiet them down for a minute and start talking to them about other things. Okay, now tell me what you eat. You know, tell me when you eat. And I spend a lot of time talking to the patients and going over their diet. And you'd be surprised the amount of information that's on the internet now that's kind of right, but oftentimes incorrect. And not every diet applies to everybody. Okay? And I'll go over and I have a handout in my clinic, and one of the most common ones that I use is a diet that reduces the inflammatory load on the patient. Because as we know, things we put in our body, that's how we interface with the environment, right? That's the only way. Plus the stuff we breathe, right, through our lungs. Everything we put in our mouth, this is how we interact with the environment, and this changes, even genetically, codes in our system that trigger cancer, trigger heart disease. I'm telling patients there's no perfect diet. Find one, we're going to take small steps, we'll find the one that suits you, and then we're going to reassess you in 3 months. And by the way, these are things that I'm going to be trying in addition to keep your pain at bay until we can get somewhere with it. Okay? This became important because narcotics, of course, as I mentioned, are not a great thing, only good for a very narrow group of people. And also, as you know, non-steroidal anti-inflammatories, which I'm sure almost everybody here has taken one in the last week, ibuprofen, Aleve, those kind of things, they increase your risk of adverse cardiac events. So guys like me can't even take it. If I can do chronic pain, I can't even take that stuff with my history. And a lot of my patients can't either. Something I've gotten interested in too is these food triggers. It's the last point there, because a lot of individuals will feel worse after they've eaten certain foods. And they didn't realize this until I said, hey, you know what, look, did you notice that this is where your pain kind of peaked at this level? At this stage of my career, I just can't keep doing it anymore. It's just the way it is. How chronic pain can coincide with certain supplement or nutrient deficiencies. One of the most common things we see in our journals, a lot of pain journals, is vitamin D deficiency and magnesium deficiency. But I found that even especially patients with fibromyalgia, and typically it occurs mostly in women, oftentimes can alleviate a lot of the pain if you use magnesium supplementation, which actually is a natural muscle relaxant, also helps with migraines at night. And vitamin D is very interesting. You know, I talk to patients about it. They don't understand that vitamin D is more than just a vitamin. It's actually functions very similar to a hormone. And so it's extremely important. So I kind of focus on those two things. And remember, I got 15 minutes, okay, with you. Okay. And I'm talking to patients are already thinking, you know, Doc, I gotta go pick my kid up, or I gotta go have breakfast, you know, and then ready to move along. And especially those with patients that have neuropathies, I start talking to them, I'll focus my discussion. It's like, well, maybe we start looking at your vitamin D deficiencies. Okay? Now there's many other of these, and these are just examples of some of the botanicals and supplements that I talk to patients about. And I've got to be very careful. I got to pick and choose what I use with them. Everybody seems to have heard of turmeric already. My gosh. And I mentioned it once, oh yeah, I've been using it, I cook with blah, blah, blah. And I say, well, you know, how do you take it, or why do you take it? And I take it for pain. I said, do you use black pepper with it? No. It's like, well, maybe try that, maybe increase the absorption, maybe combine it with ginger root. And it does have some side effects, can give you heartburn, so you gotta be careful. And I talk to them, and then I start using these things and start slowly substituting if they were on Celebrex or Mobic or Aleve chronically. I'll start slowly bringing them off of those things, okay? Omega-3 fatty acids, again, you know, it's actually a pretty good overall healthy thing to do. I'm still waiting for the really good positive benefit that I can tell patients this is where the evidence lies. By the way, let me back up a little bit here. Again, what this program taught me was when I talk to patients, I can say this particular thing really has evidence that it works. Yeah. Okay, versus saying, just throwing it out there, try you. Devil's claw is another botanical, and there's something called SAM-E, which I find helpful. I got to be very careful how I use it. It's not appropriate for everybody, especially people that are bipolar. But if they come in, they have depression and degenerative joint diseases, and they want to get off of their NSAID, and they're not getting very well with my diet and modification, I might introduce this. And again, these are all over the counter. These are not prescription. You may be asking yourself now, why don't I hear about this more? Because I'm going to tell you, this is a hit in our industry. If big pharmaceutical companies can't make money off of it and can't do a study or pay for the study, you're not going to see anybody talking about it. And we don't see it unless we attended these courses and make ourselves more aware. The other thing I want to talk about is mind-body therapy. This is something, again, I really have to sit down and look the patient in the eye and say, this is not crazy stuff, okay? Guided imagery does provide you an outlet in terms of how you deal with your pain. It's almost a practice hypnosis, which you're going to hear about a little bit later on. And how you respond to stress really determines how you react to it, okay? So if you're always anxious, you've got extreme depression, your pain score is going to be much higher than the person who doesn't have it with the same diagnosis. And what Dr. Link said too was interesting, because we are taught in conventional medicine to be what's called reductionists. We focus, especially in my pain clinic, and how I was taught traditionally, when you come in, you have a hurt knee, I'm zooming in on that knee. Okay, even if you've had your surgery before, you're still in pain, you're still disabled, I'm focused on that knee. That's how I was taught. Okay, I wasn't taught to do these other things. Here's something else you could try. Well, tell me what kind of activity you're interested in. Maybe we can talk about modification. Maybe I can try some different type of nerve blocks to kind of give you some respite so you can do some rehabilitation and recover. Okay, those kind of discussions I would have never entered in the past. It would have been, yeah, let's give it a shot now. It's like, next. People that have been to pain clinics understand this. And I hate to say this now at my level of career, but it's like a mill many times. You'll go in and shot, and maybe a couple of medications that really had no, if you look back in the evidence, really had no proof that it worked. Biofeedback is another technique that's used for people with chronic pain. I often recommend this for patients, my cancer patients that come in, they're end of life. They're probably the saddest group I have, but in many respects they're the most gratifying, especially if I can get just at least 40% improvement in pain. That to me is a win. Talk a little bit about acupuncture. I'm not certified in it, Dr. Link is. Again, it's a fascinating field how it works. The Chinese have been doing it for thousands of years. It seems to work with the opioid system. In other words, very similar to how our narcotics work. You've got to be patient with it. The best evidence for this right now is chronic back pain, osteoarthritis, and migraines. In fact, this is the first thing I will ask patients if they've done. If they come to my clinic and they have a problem, this is the first question I'll ask. Have you done acupuncture? Have you tried that? This is before I'll even try medication. And Dr. Link also mentioned some of the manual medicine. I won't rehash that again, but it's kind of interesting because when you do the research on manual medicine, not only is it effective with musculoskeletal issues, but it's also been found to be effective with peripheral neuropathies and trigeminal neuralgias. In the past, I probably would have stuck a needle in that. I would have shut that pain off pretty quick. But, again, you're sticking a needle in somebody when you can actually do something that's going to make them a little bit healthier when they leave your clinic. The best thing I like about it is, too, that I'm starting to see more evidence that it helps cancer patients. So I've been more aggressive in terms of recommending it for a lot of the patients who are in that stage. The other interesting thing, too, is that because of our opioid epidemic, we're always looking for ways to get people off this medication. Now, I want to stress something, too. People that are on these medications, this is not a character flaw. I want everybody to understand this. If I gave all of you a substance that hit a certain receptor in your brain that made you feel really good, almost everybody here would want it. Sugar is one of those, okay? I don't make a character judgment on any of the patients that come out that are on narcotics. I don't like it when they lie to me, but I don't automatically put them in a label because this is something that's been tried and some sympathetic physician did try it because they thought it would help their pain. Okay, but now we're finding out it does all kinds of bad things. In our industry, we've been talking about cannabis and chronic pain management cannabis for 5 years now. Almost every conference I go to, suddenly it's hit the, it's now legal, medical marijuana is legal here. I cannot certify it at St. Mary's because it's still considered a Schedule I medication. By the way, if you ever want to see how politics influences our ability to get a medication, read about medical marijuana. Okay, it's got nothing to do with clinical efficacy. It really has to do with political agendas. But anyways, we do have cannabis receptors are everywhere. Our body's made to receive this substance somehow. And we're not quite sure how it works all the time. It does seem to focus on an area of the brain that narcotics do. The other remarkable thing about it, I always get the response, well, I'm afraid I'm going to get too much or you're going to get overdosed. The overdoses that have been associated with cannabis have been when the patients are taking something else. They're taking trazodone, taking Valium, or they're mixing with heroin. There's never been any documented reported case of somebody. Billions of times people have been using marijuana, never one documented case of reported death from the overdose. You have to smoke 800 cigarettes, and you would die from carbon monoxide poisoning before that would happen. So, if you look at the addictive potential from it, now I am not inserting my political beliefs on this at all. This is science. Okay, this is what the science says. This is not what the politician says, not what the lobbyist says. The addictive potential for cannabis, just cannabis alone, is about equal to coffee. In fact, if you give a person one-time doses of alcohol, narcotics, and so on, methamphetamines, cannabis is down low. It's one of the lowest ones. Okay, and that's science. It's not my belief in it. And I have many of my patients that I recommend, if they ask me about it, I'm not allowed to certify. I'm going to make that very clear if there's any SSMB people in this audience. I know I can't, and that's just the policy. But they always asking me, and I'll tell them what the science shows. And if they want to try it, I'll work with them. They have to get it from another physician, and I'll work with them with the current medications that they have. But what I don't want is them keeping it from me, and I've got them on something else which does affect their attention span or can make them increase risk for falling and so on. So that's the only thing I ask for my patients. Okay, the next thing I want to talk about CBD oil. That's probably the second most common thing. In fact, I did a anti-aging conference in August, and I had probably about 5 people follow me out to my car, continuing asking me about this stuff and marijuana. And there's really so much that we don't know about it, but I've tried this about 200 patients right now. And what I find is a couple things, this actually is borne out by the science, is that for pain management, for what I use it for, I've got to really get high doses. And right now the products that are on the market are not potent enough, and sometimes you're not really sure the product that you're getting. So oftentimes when we prescribe stuff that's not like a supplement or a botanical, Jennifer and I have subscriptions to something called consumerlabs.com. We'll get on it and find out where the best product is and tell the patient, okay, this is where you can find it. If you don't mind me calling you back later in the day when I have time to do it. Okay, so you really get higher doses. Now what I did find is that the patients sleep better. And if they didn't get the pain management part, they slept better. So that to me was a plus. I mean, took them off of trazodone or Ambien and I'm not a big fan of any of those things. I mean, they give you terrible sleep. There's so many good alternatives out there. You really shouldn't be on those things anyway. CBD oil, and if you're going to take it, you have to take it on a regular basis. What I find that patients that have tried it, they did it for 4 days, it didn't work, so they quit. I said, you can't do it that way. All the studies show you've got to be taken more on a regular basis in order to get the pain management, or pain relief part of it. Now, some people do respond immediately to it. That's fantastic. The nice thing about this, it does not give you the euphoria cannabis does, or the marijuana does, because the receptors are not in the brain like they are that responsible for that. Okay? Perfect timing because I'm finished. And we'll do questions later. Thank you very much.